Hello, my name is Jerem Bowman. I'm with Healthcare Strategy Group. I'm a senior consultant here focusing on clinical integration, accountable care. I'm joined today with DJ Sullivan, a consultant on our team as well. And basically what we're going to be talking today about is it's part of our What Your Doctors Need to Know series, but we're going to be focusing on the SGR Fix and the road to accountable care. So quick overview with the agenda. We're really going to spend just a second providing some, talking about the catalyst for change, providing some context and discuss the factors that have been contributing to MACRA and how it's, its current relevance in today's environment. And then we're going to actually spend the bulk of our time on MACRA, what it is, what the implications are, and how it's accelerating the industry's movement towards value and accountable care. Finally, we're going to provide some food for thought toward the end in terms of what it takes to be successful in a value-based care environment, and the infrastructure and capabilities organizations will need to develop in order to be successful under those types of models and really get to where they're managing populations and ultimately the total cost of care. So getting into our first topic, we're all aware that the industry is changing. The signs that we're moving quickly toward value and a risk-based environment are all around us. What we're seeing is a shift away from the current model characterized by patients, getting patients through the door, kind of that heads in beds mentality that we've had under the prevailing fee-for-service world, and pushing profitable service lines, those sorts of things. We're shifting to a model where we're being paid based on value, based on the value we deliver, which unanimously translates to delivering better care at a more affordable rate. Universally, the nation's experiencing this evolution. However, different markets are experiencing different rates of change based on a set of very market-specific factors. Some things you'd want to look at to really assess how quickly your market's transitioning toward value are the prevalence of risk and value-based contracts in your market, what the competitive landscape looks like, provider consolidation, whether or not health systems, your competitors or yourselves are developing clinically integrated networks, ACOs, or even developing an insurance arm and offering insurance products. Other things that might contribute to accelerating this pace are providers, provider groups and entities gaining experience with population health-oriented care models such as PCMH, chronic disease management, and care transitions type models. Wanted to include this slide just to really illustrate the programs that are currently in place for hospitals and providers that are focused on holding us accountable for cost and quality of care. As you can see, the schedule with each of these programs is really set to ramp up as time goes on, and that's really the approach that we've seen. So it really represents the gradual transition away from our current model and the development into the development of a new business model that's going to be necessary to support increasing levels of risk. One thing that really is underlying this movement is obviously CMS and how progressive they're being in terms of shifting their business into alternative payment type arrangements that are based on value and not so much the fee for service. CMS recently announced that their goal is to have 50% of their fee for service Medicare beneficiaries transitioned into, well, their fee for service payments for Medicare beneficiaries transitioned into some form of a value-based payment model by 2018, which is really an aggressive goal when you stop and think about it, but then you consider all the initiatives that have been put in place to help them achieve this in terms of, ACOs, BPCI, the recently developed Comprehensive Care for Joint Replacement Program. All of these programs are designed to help them get there. And as we've seen historically, commercial payers typically follow suit follow CMS's lead in terms of payment reform. And so, certain markets, we've actually seen commercial payers that have that amount already of their business in these value-based arrangements, and they're depending on the market, they're extremely aggressive about pushing risk to providers. So.
Thanks, Jerem. From here, we will jump into what actually is MACRA, which by definition is the Medicare Access and Chip Reauthorization Act of 2015, which is an absolute mouthful, but is what it is. To really better understand where we are today, I think it's important to first take a step and look back at where are we historically and what has led to where we are at, and how is that going to affect where we go in the future. So the first piece in question that we want to answer is, what is the sustainable growth rate and how is that affecting where we are today? The sustainable growth rate is a formula that was enacted in 1997 that was emphasized to really calculate and cut reimbursement payments for physicians to help curtail Medicare spending. The intention was to really have and measure how Medicare spending was compared to GDP growth, and then create a conversion and apply a conversion factor that would help curtail some of the Medicare spending and really be able to help manage some of the overall influx and increase that was taking place in overall healthcare costs. The sustainable growth rate was successful for a few years, but in 2002, there was supposed to be a 4.8% reduction in this reimbursement rate, which obviously is a very high rate that would have had a great impact on many providers of healthcare. And so they began patching the formula somewhat. And they have, every year, the budget shortfall has kind of been postponed and patched year over year, and it has been emphasized it would just be added to the next adjustment period. That has taken place now for over 12 years, and in this year there was supposed to be a 21.2% cut to Medicare, which obviously is extremely unsustainable and something needed to take place. As a result, the SGR was repealed, and MACRA was actually go into effect to replace what the SGR had initially become. The intent of MACRA is to really help create a stable annual update in physician fee-for-service payments, and while simultaneously causing the transition to value-based care to take place more gradually over the next 10 years. So there are two key aims of MACRA. There's the fee-for-service portion and then the value-based care portion of MACRA that is emphasized. Essentially, MIPS, or the Merit-Based Incentive Payment System, the fee-for-service portion of the program, consolidates many of the value-based payment programs that currently exist, such as meaningful use, PQRS, VBM measures, some of those different things. Only it encourages a much more aggressive value-based payment schedule. So the transition from fee-for-service to value-based payments will be much more aggressive in that timeline. In the value-based care portion, this is intended to really incentivize providers to participate in alternative payment models, such as clinically integrated networks, ACOs, really encouraging physicians to participate in some of those more risk-bearing entities. And that's something that Jerem will actually dive into a little bit more just a little bit later on. First, we're going to look at MIPS more in depth and really try to understand what is MIPS and how is it going to affect our organization as a whole. As was mentioned, MIPS is kind of replacing some of the meaningful use, PQRS, some of those different metrics that are currently in place, but it's coming up with new categories that incorporate some of those as well. Some of those performance categories are VBM measured quality, measured resource use, meaningful use is continually going to be one of those performance categories. Then there's also a clinical practice improvement category that's going to be going into effect, and that is inclusive of things such as population management, patient access to your practice, care coordination. Some of those different things will also be included there. Reporting on a lot of these measures will take place in 2017. The reason for that being that a lot of those measures are not yet clearly defined. They have not been completely vetted out, and that's going to be taking place throughout most of 16 with the intention of reporting in 2017 and then being actually measured on those in 2019. One important aspect of a lot of these measures and categories is that they will be made much more public than they have been historically. On the Physician Compare website, there will be a scale of 0 to 100 inclusive of the rates and scores that physicians get in these separate categories, and patients will be able to go on the website, be able to say, where does my specific physician rate on a scale of 0 to 100, then also relative to those other physicians in the market, and nationally, where is my physician performing in each of these separate measures related to those other providers in the area. The financial aspect of MIPS is much more straightforward and honestly not extremely complex. There will be a 0.5% increase in physician fee-for-service rates from 2015 through 2019, and then there will not be any increase from 2020 to 2025. As was mentioned previously, there will not be any bonuses or penalties in those first 4 years, but then in 2019, when the measurement periods begin, that's when there will initially be a 4% bonus or penalty up to a 9% bonus and penalty through 2022 through 2025. And I'll dive into a little more how those bonuses and penalties work, but overall, it's going to be a net effect. So an organization that in 2019 earns a 4% bonus, there's going to be another organization somewhere else that's going to be earning a 4% penalty, so that those overall costs will offset themselves to help kind of manage the overall healthcare expenditures related to reimbursement for these services. This slide gives a very general overview and a quick snapshot of maybe where your organization falls and what type of penalties or bonuses you may be receiving in the future based upon how you report and where you measure in each of those separate performance categories we discussed earlier. As you look down the left-hand side of this grid here, the Part B reimbursement, so if your organization had a Part B reimbursement of $15 million for all of your employed providers, in 2019, you could expect, if you received the full 4% penalty, a loss of $600,000 or a penalty of $600,000 based upon your scoring. On the flip side, you could also receive a 4% bonus of up to $600,000 if you had that Part B reimbursement of $15 million. As you move right across the grid, you can kind of see how that increases and decreases based upon the penalty growing as it goes to 5%, 7%, and then ultimately 9% over those upcoming 4 years. So you can quickly look at this grid, get an idea of maybe where your organization falls. Are you a $2.5 million a year Part B reimbursement organization, or are you a $50 million a year organization? And ultimately, how is that going to affect you if you are to participate in the MIPS program? There are 3 overall exemptions for the MIPS program. One of them being participation in alternative payment model, which, as I mentioned earlier, Jeremy will discuss in a little more depth momentarily. There is also the ability that CMS is going to work on in defining a low volume threshold, which is really practices and organizations that either have really low Medicare patients or service volumes or even just overall billings. They will be exempt as they don't have enough volume to really be required to participate in one of these programs. Or then also new providers that enroll in Medicare during one of the performance years will be exempt for that initial year when they enroll in Medicare, but in the subsequent year and therefore they will be required to then participate in either the MIPS program or an alternative payment model if they choose to. So with that, I will turn the time back over to Jerem to dive a little more into the alternative payment models.
All right, appreciate it. So looking at slide 14, as DJ had mentioned, the second key aim and really, a fundamental goal of MACRA is to incentivize providers to participate in alternative payment models. I mean, this is really going to get at the heart of CMS's goal of having 50% of their physician payments tied to value by 2018. As an alternative to MIPS, so in order to basically be exempt, for your providers to be exempt from everything that DJ just talked about, they've got to qualify they've got to be participating in one of these in a qualified alternative payment model, and I'll on the next slide talk a little bit about what deems an alternative payment model to be, what it takes to qualify for one of those. So an important thing to note here is that providers will still receive, so for the first 5 years really of this program, beginning July of this year, of 2015, the physician fee-for-service rate increase of 0.5% per year is going to look the same under either track. It doesn't matter if you're participating under MIPS. If that's your aim, is to go down that track, or if your goal is to qualify for an alternative payment model and be exempt from MIPS, physician payments are still going to are still going to be increased at 0.5% per year through 2019. At that point, when those other programs sunset, PQRS, meaningful use, and MIPS actually takes effect in 2019, that's when that essentially will remain stagnant, and you'll either qualify for you'll be under the MIPS subject to a 4% increase or a 4% decrease, or if you again meet the qualifications for an alternative payment model, you are guaranteed to receive an annual rate increase of 5% per year. And so that's a great little bonus that's really been put in place to help obviously incentivize providers to begin participating in alternative payment models. But the real point of it is to help defray some of those costs associated with entering that type of model, because as we'll see here in a couple slides, it is costly. There are some investments that will need to be made up front, pretty substantial investments, to be able to function successfully under those models. And so it's really to begin incentivizing that, but then say, hey, here's a nice little bonus on top of doing that. So what it's going to take to be considered, what currently is CMS considering a qualified alternative payment model? They really haven't put out a lot of guidance around this. They've been charged with, or tasked, I should say, with refining this over 2016. So we'll likely see more guidance on this as the year goes on, as we get into next year and progress there. But as it stands, they basically said that any tax ID number, any TIN that wants to be exempt from MIPS and qualify for an alternative payment model, there's three main points here. The first one is they've got to use certified EMR technology. So that gets to the meaningful use piece of this, which essentially is saying, okay, you've got to be able to report the measures. You've got to be able to, use technology in a meaningful way. And the second one is you've got to be reporting measures that are going to be comparable to what we have in the MIPS program. Again, those really haven't been defined at this point, but over the course of 2016, that'll be one of the first things CMS will do is really refine what those measures are under the 4 domains that DJ talked about. I think one thing that we can say with relative certainty is that those measures are going to be very comparable to the measures that are currently in PQRS, meaningful use. So, just making sure that as you're designing your accountable care organization or your clinically integrated network, to make sure that your measures don't deviate too far from what CMS is currently requiring providers to report. The third point here around what qualifies providers to be eligible for an alternative payment model is basically how much risk they're taking on, and so how much financial risk they're assuming. And right now the guidance is 25% between the years of 2019 and 2020, increasing up to 50% in 2021 and 22, and then 75%, risk basically to in 2023 and beyond. I mean, those are pretty substantial amounts of risk, but I think that, as we get into building the infrastructure to accept and manage risk, it's to our benefit to begin to capture as much of that premium dollar as possible and increase our level of risk. Alrighty, so now that we've talked about kind of setting the stage in terms of what the environment's doing, what the environment's doing, how MACRA fits into that, what MACRA is, what some of the implications are, and what alternative payment models look like. We thought it relevant now to talk a little bit about how to be successful under that, because we realize that it's not just CMS that's pushing alternative payment models, it's commercial payers, it's the competitive landscape in your environment. There's a lot of things that are accelerating the adoption of these types of models, and so how is it we can be successful under them? The overarching strategy really, it's pretty obvious, but at the same time it's not. There's really this tightrope that as providers we're trying to walk in terms of continuing to operate and take advantage of the current environment, but being sure to keep an eye on what's happening down the road and designing care for a future state, and being smart and tactful about how we invest in the competencies we're going to need to manage health and populations. This really gets at timing as being a very critical component of making this transition. You really don't want to move too quickly into accepting large amounts of financial risk before you've spent the time developing the infrastructure and getting the processes and capabilities in place that are going to be needed to manage that type of model. And likewise, though, you don't want to lag behind the curve and delay building out delay taking on risk and building out those capabilities, because it's happening whether you want it to or not. Your competitors are likely thinking about it and or are developing these skills. So if you do it prematurely and overextend yourself, you risk kind of eroding your own operating margin by eating away your own utilization prior to having a payment methodology that supports the care management and all the utilization type efforts that you're focused on. While at the same time, if you wait too long, that's going to be in jeopardy anyway as your competition begins to really manage care and reduce the overall utilization of the population in your market. So what we have is this illustration on the right-hand part of the screen that we put together that we feel is really representative of all the components that are necessary to be successful in this model. We believe it really first and foremost starts with developing a vision and creating that culture that's going to be accepting of value-based care and understanding of the need to develop a long-term strategy that outlines how you intend to manage this change. Next on top of that is really developing and putting in place a collaborative structure, well, the right legal structure, but a collaborative governance model that allows you to work with providers across the entire continuum of care. It's really meant to bring together employed physicians and providers with independent community physicians and providers, and you know, allow them to work together to design an organization and begin to collaborate in ways that they currently aren't able to be able to manage bundled payments or you know, a full cap type risk arrangement or whatever the aim is. Engaged provider network is really a critical component of all of this. We use the term provider very deliberately. It extends beyond physicians. You know, it includes your acute care providers. It includes providers of really every specialty, particularly those that have a big hand in population health, you know, oncology, OB, primary care, obviously, and others. So making sure that you've got a network in place to be able to manage the gamut of alternative payment models that you're going to be engaged in. You know, I think of the comprehensive care for joint replacement program that's going to be rolled out. It's mandatory, mandatory bundle payment initiative that's being rolled out in 2016 for select metropolitan areas, and you know, ensuring that you have, you know, a mechanism basically to be able to collaborate with orthopedists and others to be able to manage that model is going to be critical. And so you know, getting into financial alignment, that's a key organizational pillar that really says, okay, you know, we're not being paid on as we used to. We're being paid now based on the value we deliver, based on the, you know, reducing costs and producing, you know, well, delivering on the various measures that we're going to be held accountable for. So we need to have a mechanism that aligns the way we pay and incentivize our providers, and of course those also those independent providers that we're going to engage in this effort. Doesn't make any sense for us to pay them on a volume productivity model when, you know, as an organization, that's not how we're being reimbursed by payers. It also gets to the issue of making sure that, you know, if we're going to be venturing down this road and investing in this infrastructure to manage care and you know, the IT that's going to be necessary to manage all of this and just the administrative and governance structure, we want to have financial models. We want to have a reimbursement methodology that supports all that. So we want to be rewarded for our efforts. And that gets back to timing and making sure that the payment mechanisms align with what the care delivery model is that you're trying to execute. Your data systems, information systems, and data analytics that are capable of monitoring, tracking, and reporting on quality, utilization, cost data across an entire network of providers at an organization level, but then also at an individual provider level. Is going to be critical. You know, being able to report these measures back to CMS and commercial payers, but then being able to report them internally and be able to show them to high-performing or even low-performing physicians to get them to change behavior is going to be of the utmost importance. And one thing that we've seen done is the development of a comprehensive scorecard that includes, you know, your quality measures that again have to be comparable to what measures are going to be in, you know, in the MIPS program in order to qualify. But making sure that you've got quality measures, cost and financial measures that you're tracking, as well as utilization measures, but making sure that you have the analytics to pull and report this data so that you can then take it to other payers, to employers for direct contracting, and basically be able to prove the value of your network is going to be essential. And you know, you think of bringing together employed and independent docs, and you know, the disparate EMRs that you're going to be dealing with. You're going to need a health information exchange to kind of pull all this data together, and then also to be able to feed it back out to all these providers. So 3 other pillars that I'll just touch on very quickly that really sit on top of our engaged provider network, because they're very heavily physician-driven. So the financial alignment, data systems, you know, there's physician input is required there as well, you know, because if you do this right, the physicians are going to be heavily involved in your governance model, so they'll be driving all of this. But you know, what we believe really are the organizational pillars or data systems of financial alignment, quality, your quality program of your organization, and your patient engagement strategy and your care management strategy really do sit on top of that provider network. And so in terms of your quality program, that just gets back to really what I'd mentioned, making sure that you have you know, vetted and identified and selected the right measures. You know, we think of it more comprehensive than just quality, but the right measures that are going to validate the organization's efforts. Patient engagement, you know, making sure that we have developed and implemented the most current patient education and empowerment strategies, and really engage them in the decision-making process, and in administering you know, their long-term care plan is going to be critically important, because you know, we firmly believe that patients that aren't engaged don't really make good partners. And so making sure that that's a critical component of your program will be essential for success here. And then of course managing care. I mean, you know, in terms of identifying who the high cost utilizers are, you know, who the chronically ill patients are, and really managing their care. That's where, you know, there's a lot of immediate cost saving opportunities if we're able to do that, and that's all supported by you know, your data analytics as well. So you know, in terms of developing a strategy, we believe that all of these components are necessary. They all work and build on each other, but they're all essential to being successful under this new era of accountable care. So with that, I just want to thank you all for your time. Thanks for tuning in. Thanks for joining us, and we look forward to another What Your Doctors Need to Know series. Thank you.